Tumor Lysis syndrome, TLS, is a potentially deadly condition related to the treatment of high-grade lymphomas and leukemias. It can occur in the absence of chemotherapy, but is usually triggered by the introduction of combination chemotherapy. On occasion, it can occur with steroid treatment alone. Awareness of the condition is critical as prophylactic medication can be given to prevent the potentially deadly effects of tumor cell lysis. Patients at high risk of TLS should be given intravenous allopurinol or intravenous rusburicase immediately prior to and during the first days of chemotherapy. Rusburicase is a recombinant version of urate oxidase, an enzyme that metabolizes uric acid to allantoin. Allantoin is much more water-soluble than uric acid and is, therefore, more easily excreted by the kidneys. Patients in lower risk groups should be given oral allopurinol during chemotherapy cycles in an attempt to avoid the condition. Rusburicase and allopurinol should not be given together in the management of tumor lysis syndrome as this reduces the effect of rusburicase. TLS occurs from the breakdown of the tumor cells and the subsequent release of chemicals from the cell. It leads to a high potassium and high phosphate level in the presence of a low calcium. It should be suspected in any patient presenting with an acute kidney injury in the presence of a high phosphate and high uric acid level. From 2004 TLS has been graded using the Caro-Bishop scoring system. Laboratory tumor lysis syndrome, abnormality in 2 or more of the following, occurring within 3 days before or 7 days after chemotherapy. Uric acid 475 mmol/L or 25% increase. Potassium 6 mmol/L or 25% increase. Phosphate 1.125 mmol/L or 25% increase. Potassium 1.75 mmol/L or 25% decrease. Clinical tumor lysis syndrome, laboratory tumor lysis syndrome plus 1 or more of the following. Increased serum creatinine, 1.5 times upper limit of normal. Cardiac arrhythmia or sudden death. Seizure.